Alaikum. Thanks for joining us today. Welcome to the 14th session of HIV Awareness, Prevention and Education Project in Pakistan, designed and led by Apna Merit HIV Committee. This project aims to reduce HIV stigma, increase HIV awareness, and increase knowledge about the disease among the HIV care provider communities in Pakistan using educational and research tools. Please note, this is a volunteer academic activity. We do not affiliate ourselves with any political party in Pakistan. Our main purpose is to open dialogue with key stakeholders and partners who are participating or responsible for implementing HIV care program in Pakistan. And all views expressed in these webinars are presenters' own views, and they do not necessarily represent their agencies. Our approach is forward-looking, and we are hoping to get constructive feedback from all of our partners and attenders today. So our moderator today are Dr. Saima Abbas and Dr. Fazia Kamal. Dr. Saima Abbas is an infectious diseases physician working in the USA and is the co-chair of Apna Merit HIV Committee. Dr. Fazia Kamal is a faculty member at UMass Medical School, Massachusetts, USA. She is dual board certified in internal medicine and infectious diseases. She had been a very among the frontliner HIV care providers during COVID-19. And personally, I know that she was very active. She was doing community outreach within our own communities here about COVID infections. So now I hand over to Dr. Saima and Dr. Fazia. Thank you.
Thank you, Fiza. Let me share my screen. Okay, Assalamu alaikum, everyone. Let's begin. Bismillahir-Rahmanir-Rahim. So we did our first webinar, which was part 1 of this topic on July 31st, focusing on iatrogenic transmission of HIV. And the first webinar was on unsafe injection practices. So this is a continuation of the same concept. How do you get HIV in the healthcare setting? And this is part 2, focused on poorly regulated transfusion of blood products in Pakistan, a very important public health crisis. Okay, so the schedule for today is our main speaker is Professor Hassan Abbas Sahir, who will be presenting for 20 minutes. And then Dr. Shabniz Hussain and Dr. Bushra Jamil are our panelists for today. And after that, we will have a discussion with question and answers. If you have any questions, please put it in the Q&A box. If you have any comments, suggestions, wisdom, experience, please put it in the chat box. So what is the objectives for today's webinar? So through the last year when we did our webinars, we realized that any problem needs to be dissected into knowledge, attitudes, and practice gaps. And then you find solutions once you dissect each gap one by one. So I am hoping that in today's webinars, our panelists and our speaker especially can address some of these gaps and give us more insight into solutions. So in the knowledge gap, what is the true burden of this problem? So I already forwarded these questions to our panelists, and these are basically what percentage of blood products are transfused unscreened or poorly screened? Poorly screened meaning you are using faulty or defective kits, so they are unreliable. Second question was, what percentage of HIV transmissions are caused by contaminated blood products? This is outside of key populations. In the last decades, the 5 out of 7 hotspots that we had, those were affecting children and adults without the traditional behavioral risk factors. And this was a very important risk factor for transmission in the general public. The third question is, what is the incidence of HIV in patients who do receive frequent blood transfusions, such as those with hemoglobinopathies, thalassemia, or hemophilia, and those with chronic renal disease? Apparently, they are also very high risk because of the transfusions that they receive. And the last question, which was very important in the last webinar as well, this culture of unnecessary blood transfusions. So what percentage is avoidable? What percentage of blood transfusions are truly necessary? The second gap, which usually gets ignored, is the attitudes gap. So changing the perception of HIV from a sexually transmitted disease to one which is iatrogenically transmitted as a blood-borne pathogen, similar to hepatitis C, is the need of the hour. Because of the stigma associated with sexually transmitted diseases, there is a lot of denial in the healthcare community, and this leads to inaction and helplessness because nothing is discussed and nobody wants to deal with it or talk about it. So this attitude really is based on changing the perception that this is definitely rising as an iatrogenic problem, which the responsibility lies on the healthcare community. The last thing which Apna Merit has really tried to do in these webinars is to bridge the disconnect between the three major stakeholders: the citizens, the healthcare community, and the government and funding agencies who are trying to govern. As far as practice is concerned, we would love to hear what are the processes and internal controls at every step from donation to transfusion. Where are the slips and the gaps, and how do you maintain strict and vigilant monitoring and not allow this to slip through? What is the availability of testing kits? Are there any faulty testing kits, and how do you handle that? And then is there a system of mandatory reporting of HIV to a common dashboard through these blood banks? In the post-pandemic world, or maybe still in the pandemic world, COVID really put every other virus to shame, but it just told us that it can be done. So we are so thrilled to have our next speaker, which is Professor Hassan Abbas Zahir, who is the perfect person to answer all our objectives. And he is, mashallah, advisor to the World Health Organization Global Advisory Group on Blood Regulation, Availability and Safety. He is the pioneer of blood safety reforms in Pakistan and is the former National Coordinator, Safe Blood Transfusion Program, and Chairman, Islamabad Blood Transfusion Authority, former head of pathology at PIMS, and he served with distinction as the National Program Manager for the National AIDS Control Program, Ministry of Health. He is also very active in the COVID vaccine clinical trial and is renowned internationally and nationally, and just completed a UNDP assignment on HIV viral load testing systems in Pakistan and future planning. So most welcome, Professor Hassan, and please go ahead.
Thank you very much, Dr. Saima, for a very generous introduction. Share my screen. Yes, so this is the title of my presentation as requested by the organizers. I have nothing to declare, and you have already very generously introduced me, so I will not repeat myself. These are the contents of my presentation, the expectation from Apna, which I'm expected to cover in this presentation, and then I'll talk about the blood service delivery system and the regulation and what was happening in the transfusion scenario prior to the reforms that we started in 2010. What are the achievements in this last decade, and what is the encouraging aspect? And I will also briefly touch upon the realistic aspects also of the work we have done so far. So these were the set of questions that I was provided. I'm afraid data is not a very strong point, so we don't really know how many HIV transfusions are caused by contaminated blood. Um, all the blood centers claim that they do blood screening, and I think they also are correct. But the quality of screening varies from center to center, and this is a big problem. So this is also covered. What is the incidence of HIV in patients with hemoglobinopathies? We don't know. We don't even know the true burden of disease. Um, we can do maybe a full presentation on this topic. It's very important. But what we know is that thalassemia patients are the single largest client of the transfusion sector in Pakistan. What strategies have worked to overcome policy implementation and governance? This is the question which is basically I'll be trying to cover in this presentation. What is the system of reporting HIV status to the blood banks and to the national transport? Basically, no system. HIV is detected in blood banks, not reported to the AIDS program, and there's no dashboard. Is reporting mandatory? Yes, HIV is a notifiable infection in Pakistan, but nobody is notifying it. Just a brief overview. The estimated HIV cases in the country are about 240,000, but the known cases are less than 50,000. So where are the missing cases? Missing cases are detected in the blood banking system, where 3 million blood donors are screened every year. Increasing numbers of HIV cases are now being detected compared to the last few years, but they are not being linked to the NACP system. Then we get migrant workers deported from Gulf countries because of HIV infection. Again, not reported in the system. Thalassemia, hemophilia patients have a high prevalence of HIV infection. Similarly, the jail population, both the inmates and the staff, high-risk group. The spouses and partners of the high-risk groups, again, uncovered. Intending migrants are all screened for HIV and other infections before being issued visas, but their data also is not shared with the system. And then lastly, a lot of HIV screening takes place in the public and private diagnostic sector, but again, this is also not being shared with the National AIDS Control Program. So despite being a notifiable infection, NACP is not collecting information for all these missing cases. And I'm afraid NACP is not in a very good shape since the last few years after the devolution of health sector. And so we need to strengthen the program before we can find all these missing cases. However, some community-based organizations do report HIV cases to the NACP, but the data management practices and the system in NACP and PACPs, there's a lot of room for improvement there, and only then we will be able to get detect more cases and bring them in the loop for treatment. So, as I stated earlier, the questions that you have posed to me, the answers to most of them are not possible because the information simply does not exist. However, if the blood delivery, service delivery system and the regulatory scenario is dilated upon in this presentation, the webinar participants would become enlightened about the real issues. And once the issues you are able to comprehend, then we can think about the solutions also. I will therefore try to share with you my observations, experiences, and my humble contribution for the improvement of the blood sector in Pakistan. And hopefully this will enable you to grasp the challenges that we faced regarding iatrogenic transmission of HIV in the country. So just an overview to start with, the blood system consists of actually 3 interrelated systems, but with clear separation of responsibilities. And the first one and the overarching one is the blood regulatory system, which is responsible for policy making, legislation, regulation, standards, and those kind of things. And this covers the blood supply system, which is basically responsible for blood collection, testing, screening, processing, component preparation, and storage. And the third one is the blood transfusion system, where transfusions actually take place, which is the hospitals where the hospital blood banks exist, and who store the blood and issue them to the patients in the ward, with the oversight of hemovigilance and the transfusion committees, hopefully. Again, this is also an overview slide. This is a very famous WHO slide, which shows that there are 3 pillars. This is the WHO strategy for blood safety, and it shows the 3 pillars, the first pillar, second pillar, and third pillar of blood safety, which is resting on 3 layers of foundations. And you can see the second pillar of blood safety is the one relevant to HIV screening, and it is a very, very important component of the overall strategy for safe blood transfusion. So let me first share with you the scenario, pre-transfusion reform scenario, which means pre-2010. And some of this scenario still exists in some of the centers. So essentially, we had a fragmented, demand-driven blood transfusion system in the country where blood centers existed in the public sector, private sector, and also as standalone blood banks. We collect about 2.7 million blood donations annually from about 650 blood banks. But there are also a number of miscellaneous centers like the chemist shops and doctors' clinics and grocery shops and things like that, which also do part-time blood work. A very important problem in the country is that there is pilferage of blood, because blood is in scarce commodity, is a scarce commodity. So we have pilferage from the large public sector hospitals. We don't have properly qualified, experienced people manning our blood centers. The doctors usually there are not qualified for the work they are doing, and the technicians are also, they've learned their job on the job. For the blood supply, we still rely on family and friends of the patients. No real proper pre-donation screening. The rapid kits are a curse in the country, and thousands of blood donations are screened on rapid manual kits, which is as good as no screening because they're very cheap kit. If you use quality manual kits, it is more expensive than automated screening. So we have problems in the blood banking also in the laboratory where cross-matching is not properly done. And at the bedside level, we have incidences of transfusion reactions which are not always reported and active. So what we have, we had on the ground situation was that in every hospital, we would have blood banks which were doing the same thing, blood collection, component preparation, screening, testing, compatibility testing, storage and transfusion issuance. All these things happening in 2-3 small rooms in every hospital. So there was suboptimal utilization of scarce resources, and many blood banks were very small volume blood banks, the duplication of resources, screening substandard. So a lot of wastage of blood. So in 2008, the government decided to fix this situation. And I was given the responsibility of doing that from the platform of Safe Blood Transfusion National AIDS Control Program initially in 2008. And we then developed a system of utilization of the German government funding offer, which was pending for last many years. So we developed this Safe Blood Transfusion Program, which completed its first phase in 2016. And the second phase is going to end at the end of the year. And I'm going to share with you what we did in all this time. The basic concept that we tried to introduce actually with success was that this is the work which is actually done in the blood system. This is starting from the vein of the blood donor and ending at the vein of the patient. And so the first few steps are relating to blood production. So we separated this work and developed large modern regional blood centers. And the rest of the work, which is blood utilization, we restricted it to the hospital blood bank level. So this is the international recommendation, and this is what we try to implement in Pakistan. And I'm proud to say that we did it successfully. So these are the modern blood centers that we developed all over the country in the first phase of the program. And not only these buildings were developed, but all this expensive equipment was also procured, and all this infrastructure development was done with the help of the German government. And once these centers started to become ready, we went around all over the country along with our German partners and the local government officials to inaugurate these centers in high-profile activities. During the time that these infrastructure and buildings were being developed, we did a lot of technical work also, because there is no point in having brand new shining buildings if you follow the same systems and the same practices. So we did a lot of policy work, not only at the national level, but also at regional level, and we made significant contributions, especially at the EMRO level, which was very much appreciated. On the basis of these policy work, we did a lot of work on legislative and regulatory aspects. Blood safety laws already existed in the country, but they needed to be reviewed and updated, and we did that. And we did a lot of technical works in the form of developing documents for having better and more effective inspections, and we strengthened. And we were working from two platforms in Islamabad. One was the Safe Blood Transfusion Program, and the other one was the Islamabad Blood Transfusion Authority. And I had the honor of leading both these two organizations. And we worked with our counterparts in the provinces to strengthen their systems also. And there was marked improvement in the blood banking service delivery and regulation as a result of these dedicated efforts by these two organizations, along with all the partners who had us do this work. And the most successful outcome of this work was the revival of the Islamabad Blood Transfusion Authority, which did remarkable work. We would document all that work every year, bring out annual reports also. They would be available somewhere on the cloud maybe. And this work was acknowledged internationally also. And WHO cited the IBT experience as a model for regional countries to emulate. And we also presented this work in different parts of the world. As a result of this successful legislation and regulation in Islamabad, all the 23 blood banks in Islamabad, they had minimum required standards, automation improved, 100% blood component preparation, 100% automated screening, automated cross-matching also in most of the blood banks, and so many other things. Basically, work was streamlined in Islamabad, and the rest of the country had to just emulate the work and repeat the Islamabad model. And for this, we went all over the country, and the partners would come to Islamabad also, and we would work on different aspects of service delivery as well as regulation to improve the entire system. This work was acknowledged in addition to WHO, the International Society of Blood Transfusion and International Hemovigilance also very much appreciated our work, and this was a source of huge encouragement for us. And you'll also be surprised to learn that even the Parliament, the Standing Committee of Health in the Parliament was also appreciative of our work, which is a very rare occurrence. They don't normally appreciate anyone, and mostly attending these meetings is not a very pleasant experience, but for us, they were very kind to us and very helpful and very encouraging. Another important thing that we did was that for the first time, we started collecting the national blood data from the source, from each individual blood bank. We started this in 2015. And so this is the latest data that we have, and this is 2018 data. And this is fairly accurate data. I mean, almost 90% of the data has been collected from the source. And as a result of the regular annual exercise of data collection, everyone started to realize that we are not going to leave them alone. We are going to come back every year and make sure that they give us their data, so that quality of data improved and they started maintaining their data management practices better. But there are still many blood banks where the data management is primitive and rudimentary. Right. So this kind of project cannot be successfully implemented without political commitment. So we tried our best to involve our political leadership wherever we could, and we would invite the president, prime minister, chief ministers, governors, and ministers whenever we could. And they were all very kind to us, very supportive, but not really contributed much. So it was up to us to really keep on pushing and get the work done. But I'm not complaining. You know, many times you would receive very complimentary remarks from different national leadership as well as international partners, because not many donor-funded projects in Pakistan are anything to write home about. So as a result of all these activities, the international blood community started paying attention to Pakistan, and all these logos that you see at the bottom are the important and key international societies and organizations which deal with blood safety, and they would invite us to their conferences, seminars, and meetings, and we would share with them the development of the blood safety reforms in Pakistan. And in the beginning, I would be going to these places alone, but gradually the national partners and experts also became sensitized, and they would also get invited. And so Pakistan was, you know, very well represented subsequently at the international blood community forums, which was very encouraging thing. And all our work would get extensive coverage in the national print media. We would also get publicity on the electronic media, which was also very important. WHO was the second after the Germans. WHO was the most important national partner. They provided us excellent technical assistance and support. We were very good with communicating our message to the general public as well as experts. Every month we would bring out electronic newsletter, and every year we would bring out a service delivery report, a regulatory report, and blood donor report as well. And this was all in addition to the social media, very active social media presence of the Safe Blood Transfusion program in the country. So in addition to these reports, we also worked and developed many technical documents which were very well suited to the national needs. Some of these documents were based on international documents, but adopted to the national requirements. And I must compliment the national experts who helped us develop these important documents, which were followed in many, many blood centers all over the country. June 14 is a very important day in the blood sector, and it is an occasion to acknowledge the services and sacrifice of the blood donors. Before the national program was established, this day would go unnoticed in the country, but we made sure that this day was celebrated in the manner that it deserves to be celebrated. And you can see from these pictures that it is very well participated. And in fact, we always followed a participatory approach in the program, and this helped for the first time to create a platform in the country. Before that, everyone was working in isolation, no coordination, no interaction. People didn't even know each other, even after spending a lifetime in the same field. So as a result of all these committed efforts, Safe Blood Transfusion Program became the national platform and the national voice of blood safety in Pakistan. And this is now the current footprint of the program, which means these pictures that you see here are the regional blood transfusion centers of the phase 1 and phase 2. And these small red dots that you see here depict the hospital-based blood banks, which are supported by each of these regional blood centers. The first phase infrastructure is operational for quite a few years now, but the phase 2 infrastructure has yet to become operationalized. And to conclude, despite administrative and constitutional challenges, SBTP not only laid the foundation of a modern blood system in Pakistan on solid footings, but also successfully implemented the project unequivocally. The paradigm shift now towards public-private partnership for managing the new reformed service delivery system, and it is now covering almost 3 provinces. This augurs very well for the future. And Shabneez will also throw light on this very important aspect. But I'm afraid the journey of reforms has not yet reached a stage of irreversibility, and there still exists a risk of falling back to business as usual, as the German donors are going to exit in December this year, and the Safe Blood Transfusion Program remains dysfunctional, unfortunately, since the early 2020 when I left the program. So institutionalization of the blood safety reforms backed with a strong political commitment, complemented by consumer, which includes the patient as well as physician. So complemented by consumer demand for improved standards can still yield the original envisaged role, but this is a role which has to be now performed by someone else. And I will conclude finally my presentation by sharing with you the best kept secret of Islamabad. And this shining brand new building that you see here is the Islamabad Regional Blood Center building, which is ready since January 2021. Unfortunately, it has yet to become operational. Thank you very much. I'll be very happy to please take your questions.
Thank you so much, Dr. Hassan Zahir. It was a fantastic presentation, and you enlightened us with so much work you have done. So really appreciate what you are doing. We've questions for the end. If you can stay with us for that. I will now ask our panelist, Dr. Shabneez Hussain, to give us a little bit of a discussion on the same issue. Let me introduce her by telling you that Dr. Shabneez Hussain is the head of the Department of Blood Transfusion Services at Indus Hospital and Health Network. She is a hematologist. Her subspecialty focus is transfusion medicine, hemoglobinopathies, and inherited bleeding disorders. So she's going to be great for our topic. She has several publications. She has experience of managing regional blood centers in Karachi and Sindh province. She's managing 22 blood centers and 3 regional blood centers in Pakistan. And she has been affiliated with Fatimid Foundation for several years as well. So Dr. Hussain, please take over.
Right. So thank you so much for a very generous introduction. Dr. Fawzia, can I share my screen? I have 7 minutes and I have 7 slides. So it will just give a nice little overview to everybody.
Absolutely. Please go ahead.
Thank you. Right. So I've shared my screen. Can you see it? Okay. Can you see the screen?
Yes, we can.
Oh, excellent. So this is just I'll just give you a brief overview of what's happening in Pakistan and how we're actually testing for HIV in blood donors. So this was one of the questions I just zoomed through in the beginning of the session. It was what is the HIV prevalence in bleeding disorders? So this is all the bleeding disorders in Pakistan who are registered at Fatimid Foundation, and the HIV prevalence is 0.01%. So this is around the same that is going on in patients with hemoglobinopathies, because they also get regular blood transfusions. It's almost the same in bleeding disorders. So what is the burden of HIV in Pakistan? Okay, let me go in the previous slide. So, right. So Pakistan is one of the four Asian countries in Asia, where incidence of HIV is increasing. The number of new HIV cases have increased from 14,000 to 22,000 in 2018, and there's a rise in HIV-related deaths. Although HIV epidemic is mostly limited to key populations, recently everybody knows children have been affected because of used needles, especially in thalassemia children, which happened in Larkana, which everybody knows about, and that's how it all started, how all the attention was drawn towards HIV. In recent articles, and this is like all the articles from 2012 to 2017, there has been a higher rate of HIV prevalence in healthy blood donors. So that is also it's a cause of concern. HIV in young population is especially of concern because in Pakistan, these are the young voluntary blood donations. This is where the blood donations are coming from in Pakistan. So it has increased by 29%. Now, what are the testing methodologies? Now, these are the testing methodologies for HIV. One of them is HIV combo. It's a machine of Abbott, and it's called LNT-S. The other machine of Abbott, it's called Abbott Architect 2000. 2000 is the one which is being used in the major RBCs, which is in Bawalpur, which is going to be in Peshawar and KPK, which is currently in Jamshoro and Hyderabad. So this is currently what's being used. Then we have further, if you go further for testing, we use NAT testing on Grifol's Panther, that's available. Then we have US FDA approved supplemental testing devices. We have real-time quantitative HIV PCR, which is the gold standard. Then we have rapid testing devices. And this is very unfortunate that according to WHO, these rapid testing devices are approved for testing HIV. This is sad, because even this equal, we have to give equal health opportunities to our patients and our blood donors also. So we need to test them with internationally approved HIV methodology machines, right? So what is being recommended is chemiluminescence microparticle immunoassay. This is widely used. It is an acceptable method for blood donor screening. Now, what is the confusion? The confusion is what can be used in clinical labs and what can be used in blood donors. So in blood donors, FDA approved machine is Abbott Prism or LNT-S, whereas LNT-I and Abbott Architect is for clinical lab testing. So when we talk about blood donors, they need to be screened through LNT-S. Now, what LNT-S requires? It requires very simply a very high throughput. So the more samples you run through it, the less the financial burden of this machine. What is the problem we are facing in Pakistan? Blood banking is not centralized. But as Dr. Hassan has given a huge brief of a very detailed brief of all the regional blood centers, it is going to be centralized in the future because RBCs are rapidly spreading, and even existing blood centers are given all the facilities of being an RBC. So even existing systems are being developed. For example, Fatmi, for example, Dow, OJHA, for example, JPMC, Jinnah Postgraduate Medical Center, so and PWF, Patients Welfare Association in Civil Hospital Karachi. So all these are being upgraded to this status. So it's not very far that we are going to see centralized blood banking system in Pakistan. It's going to be very soon, but it's going to take a lot of effort. So what is happening in Indus Hospital Blood Transfusion Services? We are a network. So when we say network, we have an annual collection of blood donors of 2 lakh annually, and we have 4 regional blood centers. We now are going to move in Khyber Pakhtunkhwa, and that will be an additional 3 more regional blood centers in Ahmedabad, in Peshawar, and in Dera Ismail Khan. So so we are now going to spread in the 3rd province in Pakistan. And this is again why I'm saying we are going to move very soon towards national blood transfusion services, centralized blood banking system. So is it very far that we are going to be using HIV, LNTS? Yes, we can, because the load will increase. So right now, what we are doing currently, we are performing all the HIV screenings of blood donors by CMIA on Abbott Architect 2000. And if it's negative, then we proceed to NET testing on Grifols and Panther. Right now, our unpublished data of 361,000 blood donors in a span of 2 years show that the HIV prevalence is 0.15% in blood donors. That is again a cause of concern. This is my last slide, and this is actually how we go through it. So the fourth generation HIV immunoassay is actually CMIF, right? And if it's negative, fine. We test two antigen. We test two things. We test for HIV-1 and HIV-2 antibodies, and we do P24 antigen. So we are testing both of these. If it's positive, we go, because according to FDA and according to this AABB, there have to be two tests positive to declare that a blood donor has HIV. So there has to be two different systems or methodology of testing those blood donors. So one is your fourth generation immunoassay, and the other, since we need two tests, so we go for forward and we do an HIV-1, HIV-2 antibody differentiation immunoassay. This is actually an FDA approved device, again for HIV, and the company name is Genius. So we actually test Genius on Genius immunoassay, and then we also do it on NAT. So we are doing replica, and I think within a period of 6 months, after we are done with all the method or all the validation, we can actually give up NAT testing for HIV. So that's the future, because we have to lower the financial burden and give quality services, quality FDA approved, ABB accredited services. So this is my last presentation and last slide, but I'll end with saying that if it's negative by Genius or immunoassay, then we go for RNA testing, and this is where we know that whether the infection is active or not. So the take-home message is, we do not leave the blood donor. We actually go towards the end, because these are the spreaders in the general population. So if you don't assess or get to the final diagnosis, we can actually be causing harm in the long run if we leave these donors alone. And to answer our question regarding SIN, yes, the data is being shared of all the HIV positive donors. There is a huge list which is being shared at the end of the month by all the RBCs in SIN to SIN Blood Transfusion Authority, because provincial have their own, there's a different transfusion authority on a provincial level. So the data is being shared. Thank you so much. That's my 7 minutes.
Thank you so much, Dr. Shabniz Hussain. That was a really nice presentation. I really appreciate. And then we have our panelist, Dr. Bushra Jamil. She has been with us helping with these seminars and enlightening us with her knowledge about HIV in Pakistan and testing and so much more. Dr. Jamil is an infectious disease physician at Al Khan University Hospital. She's the current president of Medical Microbiology and Infectious Disease Society of Pakistan. Dr. Jamil, please go ahead.
Thank you for the kind introduction. I don't have a formal presentation, but I've selected a few points from previous presentations, and I'm going to elaborate on that, and I will share my observations of what is happening in Pakistan and what has happened over the last many years. So regarding notification of HIV, so there is a lot of confusion, and the 18th Amendment has contributed to this confusion because nobody knows who to report to. The systems were never clear or in place to begin with, but then came 18th Amendment and the addition of provincial disease control programs. So institutions are required to report HIV, there's a list of infectious diseases, which we actually revised a few months ago. So HIV is listed in that. But whenever you see the diagnosis of HIV, then comes the confusion, whether it's the responsibility of any program or any center to report HIV, or is it primarily the responsibility of the AIDS control program, be it national or provincial. So this confusion has never been addressed or cleared. So HIV, if you see in the list of notifiable diseases, people generally leave it alone, assuming that this will be taken care of by the AIDS control program. And I firmly believe that AIDS control program has no idea of what to do with this kind of information. Neither are they in communication with different centers who might be reporting or encountering HIV patients. Secondly, I don't think blood banks have any mechanism of reporting HIV to the national or provincial AIDS control programs. So they may be reporting it to the blood banks, but I have never seen this communication take place between blood banks and the AIDS control programs. So this reporting, the link may be totally absent. So blood banks may be collecting their own data, but this information never goes on to the national database. So decisions may not be are not being taken appropriately where they are needed. Secondly, if a blood donor is found to be HIV positive, he or she is just given that message that we will not be using the blood you have donated, but what next? Where does that person go? There is no system of referral, and nobody ensures that this patient is registered with a program. So this is one very important missing link which needs to be strengthened. So this is kind of just opportunistic, I would say. So a good center may refer these individuals to an HIV center, or generally what happens is there is no system of referral. Then comes this issue of immigrants. So people who apply for international visas, especially to Middle East or Saudi Arabia, or even to European countries, they are screened for HIV. And now those centers are referring these individuals to at least AKU. They do come to our clinics and then we work them up and put them on treatment. But I'm not sure what happens if the person does not show up at a good center. So even people who are denied visas, there is no way of tracking them down and offering them appropriate screening and treatment and screening their families and so on. So this is another very important missed opportunity. And this is something which should be kept in mind because there is no referral system. So these were some of the issues which we encounter in our daily practice. And lastly, regarding blood banks. So a lot of good work has been done, but there are still unregulated, unregistered blood banks which are operational. And these are run by very influential people. So they continue to function, and they may be actually rolling out unscreened blood. So this kind of practice is still going on. So that is a major contributing factor to spread of hepatitis C, which is the biggest issue here, hepatitis B, syphilis, and HIV, which is becoming an increasingly important problem. So these were some of my observations and some aspects which need to be addressed. So that's it. Thank you very much.
Thank you, Dr. Jamil. Doctor, or should I call you Professor Hassan Zahid, do you have any comments? This question keeps on coming regarding standardization of blood donation, blood donors, and also the HIV test results from those donors. Do you have any input on this?
Yes, it's basically the regulatory authorities have a very big role to play here, and each province has its own blood safety law under which the regulatory authority has been notified, and these authorities have been in existence for more than 20 years now, and they have never really been effective. It was only since 2013 that the Islamabad authority became functional, truly functional and effective. And then we tried to work with the provincial partners to improve their regulation. But that only worked to a limited extent because the local leadership in those authorities was not suitable or even committed. And even that work is stopped now since I left the program in February 2020.
Dr. Shabnez, do you have any comments about this issue? You have been very actively involved in Fatimid as well as at Indus.
Yes, the thing is, the problem with us is that what actually happens. I think Dr. Vishwa pointed out a very good issue. There's no link between where the treatment is taking place of HIV patients or HIV blood donors and where they're actually being diagnosed. What actually happens in blood banks, and I think Dr. Hassan, you would agree to that. Blood banks, the registered blood banks, they are testing HIV in blood donors through, let's say, CLIA or CMIA. And then these patients, these donors, when they are diagnosed with HIV, suspected, when screened positive for HIV, they go to these, let's say, these government hospitals where testing facility and treatment facilities are available. And there another testing is taking place, and they are being tested again on screening kits. And there, when they become negative, these donors then come back to us and they say, okay, you tested as positive, and they are saying negative and no treatment is required. So I think Dr. Hassan would agree to that. This is exactly what happens. So what we need to do, see, like Dr. Busha was saying, there needs to be a link. If there is no link between diagnosis and treatment, what's the point of diagnosing them in the first place? So these government hospitals where free treatment is being provided, don't you think that the testing facilities should be better than what's already being provided in a blood collection setup? So that is a huge problem. This is what I would like to add. And Dr. Hassan, I think you would want to add something to this.
Yes, there are 2 points here. I would like to clarify, people keep saying registered blood banks and unregistered blood banks. I think there's no difference between the two because regulation is not effective. So the registration is not meaningful. The inspections that take place of the blood banks, they don't mean anything. So the licenses don't mean anything because it's just not working, the regulation system. And in most of the provinces, it's just not there. It's only on paper. So this was one point. The other is, HIV is notifiable infection. Even if it was not, there is nothing to stop the NACP or the PSCP in reaching out to the partner organizations, for example, the thalassemia centers, and trying to find out how many HIV cases do they have in their database. Similarly, they can coordinate with the immigration authorities and the NGOs and the CBOs. A lot can be done. You just need the right leadership and some commitment and dedication, and you would have better statistics.
Thank you so much. Let me see the chat. I think it is firing up with a lot of questions here. I'll start with the first question here. Very important topic today. The literature shows that blood transfusion accounts for 11% of the disease burden. And this is old statistics. Can you share the latest stats? I think Dr. Shabneez, you mentioned some statistics in your presentation.
Yes, I did. So the latest stats is, like I said, I just showed the data. It's an unpublished data, but this is what's been happening, because if you look at the literature, after 2017, there's no major, not in 2000, after 2015, that was the last time a major data actually got reported. And after that, there are just, tertiary care hospital type of data, which was coming up. So the data that, because Indus is right now the largest collector of blood collections, the largest one, it's across the network. So 2 lakh donations per year. And of the collections from 2018 till date, there have been 0.15% reactivity of HIV in blood donors. So that is your current happening data, 0.15% in blood donors.
If I may add here, the data also needs to be looked at in proper perspective, because this prevalence, the data shows the prevalence. This includes screening on NAT, chemiluminescence, ELISA, and the totally substandard manual screening kits, which just do not pick up infections. So you may have only, say, 2% hepatitis C infection from a city, which is known to have 10% or more HCV prevalence. So, these kits just don't pick up these infections. So, you have to take that and keep that in mind also. Data is not of good quality because the screening is not uniform or of good quality.
Can I interject? So, at the end of all our webinars, it all comes down to regulation. So I have a very painful question, which has been more painful for us, is there a possibility of a neutral regulation authority? Is that for any problem in Pakistan, because it sounds like that the government is overwhelmed and their implementation is weak and governance is weak. And, you are both in positions of power. And whenever you have been in power, you have done what needs to be done. That's what it sounds like from your presentations. So if it can be done, can such an authority be created, like a neutral, because we have the Global Fund involved, we have, advisors from the World Health Organization, everything dies at the regulation level. So
Yes.
please, both of you and Dr. Bushra.
Yes, this is a very important question. First of all, we should have one regulatory authority for the entire country for regulating blood. I mean, we have one NEPRA, one OGRA, one PEPRA. For everything, there is one national regulatory authority, but for blood, we have separate authorities in each province, and even they are not functional. But the problem here with the bureaucracy is that, at least in the case of blood sector, they don't even see the distinction between service delivery and regulation. And you'll be shocked to learn that, this Islamabad Blood Transfusion Authority, which was acclaimed at the international level, they just shut it down and it is no more in existence. And they didn't even ask me before closing it down practically. And they thought what they, in their wisdom, they tried to merge it in the Healthcare Commission of Islamabad. And they thought it was a very good idea. And they didn't bother to ask me. And by the time I learned about it, it was time for me to leave. And so for the last almost 2.5 years or more, 3 years, there is no regulation in Islamabad, despite the fact that everything was streamlined. And now, I still get calls from the blood banks asking me, when are you going to come and do our annual inspection? Because they found it very, very useful for streamlining their own affairs at the organizational level. So this is a problem which needs to be solved now by someone else, because I'm not in the system anymore.
So this is really sad. This is really sad to know. Is there something, I understand you're saying that somebody else needs to take over this. Who do you think is the point person, and what can all of us do to help?
I mean, they need to, notify my replacement in the blood program. I was the pioneer manager, and I conceived and planned and, started the program in 2010 and continued for 10 years. But they never replaced me with anyone. It was just one bureaucrat after the other. In the last 2.5 years, I've had maybe 5 or 6 successors, each one more clueless than the last one. It's the responsibility of the health ministry, health secretary.
So now each provincial authority is running on its own, like the Balochistan authority is working on its own. I don't even think it exists, but the Punjab is doing it.
Paper.
Punjab is running on its own, Sindh is running on its own. Otherwise, all the data which was collected on a provincial level used to be shared with the federal authority, which was actually being run by you. That's how it used to happen, right?
Yes.
All the provinces used to gather their data.
We would have to chase them for months and then get the data and analyze it. And it was only towards the fag end of the year that we would be able to collect all the information, analyze it, and be able to compile the annual report.
Yes, but and then you had the link with the international authorities. Then the data actually got shown somewhere in international, communities. So that was the link. So the chain is broken, basically. Yep.
Yes, every few years, WHO brings out global database report, and the latest report has the 2018 data, but next time there will be no data from Pakistan if nobody takes over from my work very soon.
So this is useful information, and I think we all spent like an hour today discussing this. I want to learn from you all and get feedback from others also in that, so that we actually are able to come to take a step. And I think Dr. Fizaglani will like so um, agree that we are doing these seminars with the purpose of achieving something, right? Not just like talking about it and then saying goodbye at the end. So what is the suggestion? What do you think are the next steps to restart this process? Both of you. My question is for Dr. Shabni Hussain as well as Dr. Hassan Zahir. You guys are in the front lines sort of over there. How can we again restart the process of standardization of the labs for blood screening of donors? And
Someone needs to talk to the health secretary, because no one in the health ministry is going to tell them.
There has to be a team of of doctors who are actually working in the same field, and they need to go as a delegation. That's how it's going to happen. So that will only happen if people are actually concerned about it, concerned about HIV. So like if Apna is doing a webinar on HIV, that is bringing the problem to the forefront. If this starts happening on a national level, I think that's how people, the more you highlight the Society of Hematology, maybe they can form a delegation, and Dr. Hassan can be a part of it, and maybe that's how these federal people, I think they listen to a delegation more than one person speaking. That would be more effective.
My question to Dr. Bushra. Dr. Bushra is president of MMIDSP. What you think is the society can do anything? We can partner with you guys, and we can help you guys to take this initiative.
I think society can play an important role in highlighting the issue and emphasizing and re-emphasizing the importance of actually having regulation in place and implementing it properly, and guiding those found to be HIV positive to the treatment centers. So that is one very, very important link which was never established. So I wouldn't say the link is broken, it was never established. Then comes the system of strengthening the system of reporting. Again, one of the biggest problem is weak or absent leadership. So you have totally irrelevant people sitting in places where you need to make these important decisions. So if you do not have people who understand the issues, what can you expect? You can expect the current situation we are in. But the society can play an important role, but we need to forge linkages with the hematology societies and with APNA, and just start highlighting this and actually invite ministers and so on and so forth. Although the duration of ministry, being a minister, is also very limited and short. So you start working on people or groups of people, and then the government changes. So what to do? It's a lot of time, hard work, and dedication, which is in addition to what we usually do. So just a lot of additional work is required with dedication.
As I said in my last slide, we need to develop consumer pressure. The physicians and the patients need to demand from the government quality in the blood sector.
So let's team up together and start writing these reports. My question to all three of you. I go back again, education of healthcare providers. So is there something we can do, require some certification of everyone working in the blood banks? And this can be done by MMIDSP or any authority who regulates these, or means who is overseeing these blood banks, that every person touching the blood and working in the blood bank should be certified in some standard way. So what do you all think? Is it possible to do it in Pakistan, or system is not ready for that?
The improvement in academic qualifications for experts working, medical personnel working in the blood sector has started happening. We did a lot of preliminary work from the platform of Safe Blood Transfusion Program, and now Indus has actually started degree and diploma programs in affiliation with a medical university. So that work is going on in an encouraging manner. What is missing is that the system has become dysfunctional, the overall system. That needs to be fixed. And the solution lies in appointing a suitable leadership at the national level and also provincial level in the service delivery programs as well as the regulatory authorities. The rest of the work would then be covered by these right persons for the right job.
Mm-hmm. Because
Thank you.
MMIDSP has already conducted so many workshops. When the HIV epidemic happened in Larkana, there were so many workshops and included, and Dr. Bushra, I think, was leading it. There have been so many training sessions, online webinars. Isn't it true, Dr. Bushra? There were so many of them.
Yes.
And
Yeah,
you included mass physicians, and everybody was a part of it. So it has already been done. But then, you know, it's already been done. It's all ends up in
it needs to continue actually. We have not been able to spend a lot of time on that. We actually launched the ECHO program as well. So we just need to revive it and actually try and address these issues. Yeah.
You know, I am very strongly in favor of accountability. So think about a small scenario. I am telling you, let's say one blood bank, and let's say you have 3 contaminated bloods given, and you find, the authority find that out. We should have a system who screen that blood, and that specific person should be accountable for his mistake. And that is, I see, only way to correct the system. Put the final burden on the person whoever did it. If he's not registered, he should be out of his job. He has to get some certification, some training, and that means all of these societies. I'm again putting on MMIDSP that these societies should offer continuous courses, continuous training. Here in USA, every doctor even need to renew their license every 2 years. And Fozia, Saima, you guys know that very well. So the accountability is something which is, I always feel, missing in Pakistan. So any idea on that? Any comments on that?
Maybe you're absolutely right. Everyone has to be accountable for their work, but you need to fix the system first. If you're not providing an enabling environment, safe environment, conducive environment for the workers to work in, you can't really blame for the system faults and put them on the individuals. No one will be left in the field if we adopt a punitive approach in a country like Pakistan.
I like this comment on safe environment for the workers, because actually it is very unsafe to practice ethically in any sector in Pakistan. And with the blood banks, people have actually received death threats, people who've tried to fix things, because many of the blood banks are being run by very powerful politicians. So who is going to put their life at stake just to rectify the practices? For what? When the system doesn't support you. That is one very, very serious issue, and which cannot be overlooked. But what we can contribute is actually start offering very simple, short courses for all the blood bank personnel, and then actually suggesting referral systems, suggesting to people that they need to refer these individuals to a treatment center. It is not enough to screen somebody and to tell them the diagnosis. People have to be directed to a proper center to be screened, confirmed, and then offered treatment. So that has to be done as well.
To the nearest ART.
Yeah,
Nearest
yeah,
ART center,
nearest.
right, Bushra?
Yeah,
Yeah, that
yeah,
would make
yeah.
sense. Mhm.
And thank you, Bushra, for answering all of those questions. I don't see any more questions in Q&A section, but I saw there were two raised hands. One was by Dr. If I am saying the name right, Dr. Sasui. So are you still interested in asking any question, or did you already write your question in the Q&A box? Dr. Sasai. I'm not sure I'm saying the name right, but I can see him in the parts. Okay. So any other question, Fozia, Saima, Dr. Hassan, Dr. Shabnis, and Dr. Bushra? Any other comment?
I have just one stupid question. Can this whole system be privatized? Because the government has failed and will continue to fail, unfortunately.
No, this is actually a very pertinent question because the regional blood centers that we have developed, they are being managed on two models. Some of the centers are being managed by the health departments themselves, where there is no administrative or financial autonomy. But in Sindh and Punjab, they are managing their regional blood centers through outsourcing. And Indus is one of the key partners. They are managing 3 centers. And there's just no comparison between the working and the results of the two systems. By far, the privately managed blood centers are doing a remarkable job, especially Indus is working, their work is international level work. I just wish that instead of outsourcing to different private sector partners, just one partner would be selected for this work. And I'm glad, and I would like to share this information with you that in KP, they've just decided on outsourcing their 3 RBCs, and all of them have been awarded to Indus. And so in 3 provinces, we are going to have RBCs managed by private sector, and 6 of them by Indus. So, in a very short period of time, you're seeing a paradigm shift, and this is working. And maybe the other provinces also, regions also need to do the same. And if that happens, especially the center in Islamabad, it's almost 2 years now, and it is lying there fully equipped and staffed, and nothing is happening there.
Yeah, I just have Pakistan has done a reasonably good job in controlling COVID, right? So they recognized it as a problem. They recognized it as pandemic. They have not recognized HIV as an epidemic yet. And I think the moment this realization comes, probably more will be happening. But that realization has to come as well. That's what I feel like is happening.
You're absolutely right. HIV and blood safety need the same kind of political commitment as COVID and also polio.
Absolutely. Absolutely. So I don't see any more questions over there. Anyone else has any comments or suggestions or anything?
Even regarding the training sessions, regarding certifications, everything, and Dr. Feza, I'm answering your question, your concern actually regarding certifications. So even at Indus, not even one of the technologists, after even acquiring their degree, they're undergoing a very intense training program. And unless they get all their competencies through, they're not allowed to go and work on the benches. And that competency is being taken by the training department. And another competency is being taken by the quality monitoring directorate. So the best thing about in this hospital is that it has a separate QMD department and it reports directly to the board. So we are keeping quality checks across the network. And all these technologists are being trained on a yearly basis as well. They have to undergo competency evaluation on a yearly basis. So one can simply not do blood banking unless they are 100% competent to do those testing services. The best thing I think which happened to Pakistan was the regional blood centers, because this is where all the blood is being utilized. Very few people are affording in this country, and the masses are actually sitting in those public sectors. And this is where regional blood centers have come in. So if you want to make a change, this is how we make a change, by targeting the public sector hospitals. And I think, Dr. Hassan, yes, one more thing to add, Jamshoro RBC and the linked hospital-based blood banks in Sindh, they are the first public sector blood banks which are ISO 15189 certified. It just came in this year. So we are progressing. It's not as if Pakistan is not doing anything. It's gonna be, as I said, it's like it's the speed of light, because now people are actually talking about blood banking. They're talking about blood transfusion services. 2 years ago, we did not have any hematologists who wanted to do blood transfusion. Yes, Dr. Hassan. And now there are more and more hematologists who are concerned about blood transfusion services, and we have more and more HR coming up in the form of technologists and in the form of hematologists. So things will look up. And I think all we need to do is work on those paused HIV certifications or training courses. And I think we are there almost, hopefully.
Very
Love
good.
your-
So good to hear. You guys are doing great. The only thing is we need to do a little bit more from every direction. If you
Yes.
guys are leader in this, all these education stuff, we need to make it more public so other public sector can follow. And I will again say is this is great that you guys are giving the training to the technicians, everyone. Just start this licensing program. So they have license for 2 years. Then after 2 years, they have to renew their education. They have to renew their training. So because I am a faculty at Brown, and every year in August, I have to do 18 courses in HIV care and all of that. So 18 courses, it takes me like 2-3 days to sit and learn everything and then give the exam. If I don't pass, means I'll be really drilled down by my bosses. So this is the system we need to do and make everyone responsible of their own job and their, what you say, the role. Thank you.
Thank you.
Thank you, Fiza. I have one last comment for Professor Hassan. You had mentioned something about the viral load testing systems. If you could just briefly highlight that.
Yes, the National AIDS Control Program had outsourced the viral load testing for the patients registered in its ART centers in 3 provinces. So I was asked to do an assessment of that as well as the complete system. So there are 6 places in the country where viral load testing is being done. And as you know, this is a very important component of the whole epidemic management. This is the third, 90 or 95. So, this is an integral part of the management of the patient. So I did an assessment of this system, and it was, I was reconnecting with the HIV sector after 10 years, and I found that the NECP was not even a skeleton or a shadow of what it used to be in 2010 when I left the program. So my report, which was supposed to be on the assessment of the viral load testing system, is in addition to that also a mini program review. So this is something maybe you would find very, very interesting to know, and I'll be happy to share those findings with you if you want me to.
Sure, I think we'll have to set up the webinar to share those findings, but thank you so much.
So for everyone's information, our next 4 webinars will be talking about the issues faced by ART centers in each province. So 4 provinces, 4 webinars. And at the end of those 4, we'll create a comprehensive report on issues faced by ART centers and all these 2 iatrogenic issues, like webinars issues, and we'll create a report and we'll send it to all. We'll invite many funding agencies and many government agencies to attend our last webinar of the year. But meanwhile, we are writing reports on every webinar. And soon we'll try our best to publish these findings, whatever we discuss. So, Saima and Fozia, there are a few comments in the comment section if you want to take care of any one of them.
Sure.
The last one, Dr. Ghulam Kader. Need of ownership.
Oh, the teaching medical universities
Yeah.
should have to start certificate programs of infectious disease for all the doctors. I think we don't, does either one of you have any link with medical colleges? And
Other than Bushra.
yeah,
So
Bushra.
Bushra, you want to talk about if medical college can start any degree or certification program on these for these technical posts?
There are issues with starting certificate courses, because then people do these small courses and pretend to be experts. And that has been a major worry. And that's why at least AKU refrained from offering certificate courses, although now we will be starting a certificate course in infectious diseases because subspecialties have been allowed to do that. And the same goes for diploma courses. So there is this potential for misuse of these courses, which are just to enhance your knowledge, but not to use them as a degree or to advertise it as an expertise, which it may not necessarily give you. So yes, AKU will be offering a course in infectious diseases, and then MMIDSP has been offering short courses for GPs. So this year, AKU will be offering a course, but there are very few ID clinicians who can actually run such courses. So this will be a first step towards it. As our fraternity grows, I think we will expand from institution to institution, and the courses will be offered widely eventually. But we will be starting from AKU this year.
That's good to know.
Thank you. So Saima and Fozia, you decide.
I am trying to see if there is any other comment or question remaining. I think I see one comment by Dr. Saswi. Where Apna team will focus tertiary public health sectors. If we work cumulatively because mass population visit tertiary healthcare sectors such as upper or lower Sindh, we start from population per area. Yeah, I think this question was already answered. All right, Saima, do you see anything else?
There's one question about who is the head of NPM right now. I think you said nobody, right, Dr. Hassan?
NPM of NECP?
The blood safety NPM head.
Yeah, it's as good as nobody. Because it's a totally, non-technical person from the ministry. It's always a joint secretary, one after the other. They keep on changing them and shuffling. So it's practically headless.
Okay, well, I think that was a great webinar. I'll let Fozia finish up.
So I just want to thank you, all of you, and we have learned a lot as a team, and I think Apna Merit will continue to hold hands and progress in this work with all of you. And special thanks to Professor Hassan Zahir and Dr. Shabnez Hussain and Dr. Bushra Jamil for always being there, helping out with this, and really appreciate your time.
Thank you very much. It was a pleasure.
Thank you.
Thank you.
Thank you.
Thank you. Khuda Hafiz.
Hafiz.
Hafiz, everyone.
Khuda Hafiz.
So it went well. Mute.